Hello, everybody, and welcome to this Meet the Expert SHOT webinar. Today's session will focus on incorrect blood component transfused. The webinar will include a 25 to 30-minute presentation, followed by a Q&A session and a short feedback poll at the end. A few housekeeping points before we begin. Your microphones have been muted for the duration of the webinar. The session is being recorded, and you may hear the recording notification shortly. The recording will be available on the SHOT webinar in the coming days via the Education Resources page for those of you unable to attend live. There is no chat facility during this webinar. However, if you have any questions, please submit them via the Q&A box and we will do our best to address them during the Q&A session. Live captioning has been enabled via Zoom. If you prefer not to see the captions, you can hide them using the toolbar option, Hide Captioning. Our panelists for this IBCT webinar are Nicholas Warbick, SHOT Laboratory Incident Specialist, Dr. Shruti Narayan, SHOT Medical Director, Emma Milzer, SHOT Haemovigilance Patient Blood Management Specialist, Karen Hughes, SHOT Operations Manager, Mike Dawes, Medicine and Healthcare Products Regulatory Agency, and Dr. Megan Rowley, SHOT Steering Group Chair. Here is a quick overview of the session, and I'll now hand over to Nikki for the presentation.
Thank you very much, Claire, and thank you for everybody attending, those who are here live and those watching back as well. So I'll just give you a quick overview of what we're going to go through today. There's going to be a overview of the most recent SHOT report, so the 2023 SHOT report, and we're specifically looking at the IBCT, so that's the incorrect blood component transfused. We're going to hopefully have some case studies as well. And at the end, we're going to enable the Q&A session. So we'd really like you to get involved, ask your questions, any burning questions for the clinical side, the lab side, and we've also got Mike here representing MHRA. So please do feel free to ask any questions at the end. You can be putting your questions in. If something pops into your mind as the presentation goes along, you can stick it in now. We'll ask them at the end. Okay, just to remind everybody, all cases are completely anonymized. We only use SHOT cases for learning purposes. It's everything that any case that I've included have all been reported to SHOT, and it's representative of the data. So it was just to let you know there'll be no patient information in there. Okay, so when we looked at the incorrect blood component transfused, when we look a bit more closely, so this whole pie chart is there were 3,833 SHOT reports last year. So that was the 2023. That's the most recent report, 2023 report. And of them, 356 of them were incorrect blood components transfused. So just shy of 10%. That is slightly increasing on recent years. So it was around 8.5%, 8.4% in the last couple of years. So we have had a bit of a jump. We are going to tell you where those jumps were as we go through the presentation, but the lab area has particularly jumped up in this particular category. Okay, so when we talk about incorrect blood components transfused, what are we talking about? So I know there are an awful lot of acronyms. So we split them into 2 points. So an IBCT event, we split into 2 points. We've got wrong component transfused. That's a category of its own. And that includes wrong patient transfused, wrong group being received, or the wrong component type being issued and transfused. And then we've our part of also IBCT errors and events, we've got specific requirements not met. So that's probably things that you're more likely to have heard of. So CMV irradiated, maybe not receiving the right phenotype or the antigen matched. It all in this category also includes incomplete testing. So we will go on and talk about some of those lab errors and where electronic issues been used inappropriate as well. So they're also included in specific requirements not met. So on the left-hand side is the 10 steps in transfusion. SHOT use these 10 steps to allow us, obviously the whole process is the whole process of transfusion is huge, all the way from the decision to and consent for the patient, all the way to administration. So we chop that up into 10 parts, component parts, and that allows us to look for trends, for errors, for weak points. So over on the right hand side, you can see this graph is representative of those 10 steps. And this is last year's data looking particularly at the clinical areas in the blue. So those weak points, really, the most errors we received for example, wrong component transfused were at request, at sample taking, but a big chunk of them were at collection and administration. So those are our weak points. And you can also see specific requirements not met were the vast majority of them were at the request stage. So just not asking for that requirement and letting the lab know that that's needed. And the other side of that coin is the laboratory errors. So they're in the middle. So they tended to fall into sample receipt and registration, testing and component selection. Now we will go on and talk about each of these, so wouldn't expect you to remember all those, but it was just to show you how SHOT break that data down and allow us to look for themes and trends. Okay, so when we looked at the data to do with incorrect blood component transfused for 2023, there were no deaths related to transfusion, but unfortunately we did have cases of major morbidity. That included 2 clinical errors that resulted in ABO incompatible transfusions and 4 lab errors that resulted in patients receiving K-positive units and going on to develop anti-K. And we would absolutely class that as a major morbidity, that impact on that patient and future pregnancies. So they were our 6 major morbidities. When we particularly look at the ABO incompatible transfusions that happened in the most recent report, so this is over time. You can see we have peaks and troughs. We had a particularly a trough in 2021. Unfortunately, that has started to creep back up. So you can see over on the right-hand side is our most recent one. So we had 7 red cell ABO incompatible transfusions and 3 plasma-based ABO incompatible transfusions. So we will go on to talk a little bit more about them. When we break that down, I thought it was important to note that actually, I think before starting with SHOT, really, I think the thought of a death to do with ABO incompatible transfusion used to be something of the past, but actually you can see here, this is the harm to the patient. So you can see in 2022, there actually had 2 patient deaths to do with ABO incompatible transfusion. And then most recently in 23, we had 2 major morbidities, like we've already mentioned. What other things we're doing? We will talk about resources towards the end, but this was a really interesting paper that SHOT were involved in, looking at the ABO incompatible transfusions throughout Europe. So we looked at that. We worked collaboratively with the French and German teams, and it was looking to see if we could benchmark what works, what doesn't work, what contributory factors were involved in these errors. So it's well worth a read if you wanted to have a little bit of look what's happening across Europe. Okay, so when we look at those 10 steps in transfusion, and this is specifically to do with ABO incompatible red cell transfusions, where are our weak points? So sample taking, that tends to result due to wrong blood in tube. So the wrong person is bled, or the right person is bled but labeled incorrectly, and the wrong group is allocated to a patient. Unfortunately, that results in the patient receiving the wrong blood group for them. Testing, we do see a few ABO incompatible grouping errors. Component selection, that tends to be the bigger issue in the laboratory. Issuing on one sample, issuing in their limbs not being able to prevent ABOI, particularly due to plasma, which again we will talk about a little bit when we talk about the lab errors. And then the 2 big ones for the clinical area really are the component collection and the administration. So both of those were really to do with patient identification errors. So things we tended to see was the wrong collection slip used, the wrong request taken to collect the units, collecting multiple units at the same time, taking them to the wrong location and them not being checked, which falls into the next part, the administration. Again, the wrong patient being transfused, no checks done, not checking the unit, checking away from the patient's side. So that might be checked in a side room or checked at the nurse's station. So these are the typical errors we see that lead to ABO incompatible transfusions. When we look at the ones from last year, so these are there were 8 clinical errors. 7 of them were due to red cells. And all of those red cells were related to a group O patient receiving a non-O red cell unit. When we look at the lab errors, they were both to do with plasma. So they were both to do with group O FFP being given to a non-O patient, and we would class that as an ABO incompatible transfusion. And when we look at this is an example of this case from last year. So we had a group O patient with myelodysplastic disorder on a hematology day unit. The red cell collected, the red cell was collected, sorry, using a prescription chart, but unfortunately there were 2 units in the fridge for people with the same surname. So, but only the surname was used to check the unit out of the fridge. 2 nurses independently checked the unit and checked the patient, but only checked the wristband against the prescription. They didn't check the actual bag or the label on the bag. The patient had already received 1 unit prior, and the second unit was collected by a trained nurse, but quite quickly, so within about 45 minutes, the patient developed quite serious symptoms. So rigors, vomiting, an increase in BP and a reduction in hemoglobin. The unit was very quickly stopped and the clinical team were informed. And when we looked at what kind of contributory factors we saw when we looked into this case, 2 patients with the same surname but on different wards. The patient was deaf, so was having difficulty understanding the nurses and the requests that they were making of them. There was a distraction. The patient was quite upset because there'd been a prior delay. So there was a slight bit of rushing. There was a felt distraction in this case. There were interruptions as well during the check. So the patient required to go to the bathroom. So that interrupted the process and they didn't start again. And unfortunately, it did result in a patient being admitted to MAU and with the potential to move to intensive care as well. So that's just a typical example, unfortunately, of where those contributory factors, one adding onto the next, which unfortunately resulted in an ABO incompatible transfusion. Okay, so when we're looking particularly at clinical errors, so this is to do with the whole of the IBC category. So this small piece of this one is looking at the wrong component transfused. There were 18 patients that were given the wrong units due to clinical errors last year, and you can see most of those were due to administration errors. 17 wrong groups given. So there's a bit of a spread there. So the request was the biggest chunk. So just not letting the laboratory know that the patient needed a particular group of it might be due to treatment or it might have been due to a transplant. They were our big chunks of those areas. And then also we had 15 wrong types. So again, the wrong unit being requested and or collection of the wrong unit and given to the patient. So given something that they didn't need. Okay, so this it was a resounding theme through the whole of the clinical events that happened in 2023 to do with incorrect blood component transfused, that patient ID is fundamental. So this was one of our recommendations, making sure that staff are trained in correct patient identification, and that's provided to all staff. I mean, this is not just a transfusion related issue. This is for everything really. So when we look at specific requirements not met, what kind of clinical errors did we see? And you can see the big chunk of by far was patients receiving units that were not irradiated. So, and the vast majority of them were because of an error at the request stage. So the clinical area know the patient needs irradiated, they just don't let the laboratory know. So the lab aren't able to provide. When we looked at when we split it down, what kind of patients were being affected. So typically it was Hodgkin's lymphoma and patients on purine analogs as well. So Hodgkin's lymphoma often can be historical as well. So it might not be clear in patients' notes to let the clinical and the laboratory area know. And like we said, the vast majority of those errors in the specific requirements not were due to the requesting, so just not requesting the right component. We will go on and talk about the particular weak points, but transplant patients, it was a resounding theme in the most recent report that this was a weak point. So just making sure that all the clinical areas know that patient is a transplant patient and the laboratory are aware and they can put rules and alerts in place to ensure that the right patient receives the right blood at the right time. Okay, so when we look at laboratory errors leading to incorrect blood component transfused, there were actually 227 lab errors in this category, and that is actually quite a big increase for both of those subcategories. So the wrong component transfused and the specific requirements not met. So the biggest jump was the 65% increase in WCT, but you can see again there's nearly a 50% increase in specific requirements not met. So let's look a little bit closer at the data and see where those errors occurred. See, the big chunk across the middle was component selection. So the laboratory picking the wrong group for a patient. Again, as we've talked about, those transplant patients, they appeared quite a lot in this group as well. So just picking the wrong group for a patient and issuing it. And there's slightly less in the errors occurred, but in testing also resulted in wrong components being issued and sample receipt and registration. So not adhering to information that's been provided by the clinical area and not inputting it into the IT system to help prevent these errors. So unfortunately, 62 of units of the wrong group were issued by the lab, which is an awful lot with the potential to cause harm to patients out there. So this is just when we scratch the surface a little bit more, what kind of gaps do we see, what kind of areas are prone to errors. So like I was saying, the transplant one's the big one across the top. So the wrong ABO or D being issued to a transplant patient. We are aware transplant patients are extremely complex. We are trying to improve the way we ask for information on our reporting system as well to see where the patient is in that transplant process. And we are trying to promote some communication tools and some shared care documentation and resources as well, which would hopefully improve the communication in this area. We also saw a big chunk of ABO and D mismatch being issued by the blood bank. You can see there's both ABO compatible and D mismatch there over on the left-hand side. And unfortunately, we did see a small proportion of adult units being issued to neonates in error. Okay, so I suppose the learning from that is a big chunk of those issues potentially could have been prevented by having really robust IT systems in place. This is a balance between IT and knowledge. What we'd also want to see is the laboratory staff have enough knowledge and skills within themselves and hopefully not need to rely on the IT to catch, but we would like the IT there as well to prevent ABO incompatible transfusions or the wrong unit being issued. Those alerts and those algorithms all would improve patient safety. Okay, so this is a case to do with ABO red cells being issued to a transplant patient. So we had a group A patient received a group O transplant, and the patient was actually grouping as O pos. There were LIMS alerts in place to give group O red cells, but unfortunately, at the point of issue, the BMS overrode those alerts and issued group A red cells, which was the patient's original group. Thankfully, in this case, there were no harm to the patient. And again, when we looked at those contributing factors, what influenced this error, the BMS hadn't actually completed the testing, so they hadn't authorized the grouping screen prior to issuing. So possibly the rules in the LIMS weren't actioned in the right way, so thus not preventing the issue. The BMS was actually called in to cover the shift at really short notice, so they felt that that was something that had contributed to the error. They were rushing to complete the workload that had been left during the day. There were LIMS notes used as well as flags, but often we see errors occurring where you're only able to use the notes section, which doesn't actually prevent you issuing the wrong units. Obviously, ideally would be an algorithm or a flag used in some way to prevent and really be in the BMS's face in the lab to say, and we would need those alerts to be actionable as well. So it's telling me it's something, and this is what it wants me to do. Unfortunately, the error wasn't noticed for 12 hours. And when it was, there was a second unit already out in stock. Out in the issue fridge waiting to be collected, but that wasn't brought back to stock. In this case, it wasn't given, it was brought back because it wasn't needed. So those are kind of contributory factors we routinely see. When we look at lab errors leading to specific requirements not met, so the big chunk at the top was to do with incomplete testing. So that might be the main areas tend to be panels not completed, antibody screening at panels, potentially phenotyping. Sometimes it's even the routine group and save. Sometimes it's even the quality control hasn't been done. But we would class those as incomplete testing. Incorrect phenotype being issued. So either that's due to testing errors, not not determining the right, not completing testing, or not determining the right phenotype, or selecting the wrong units when you do have a phenotype available to you. And we do have a big chunk to do with inappropriate electronic issue. We would hope at this point that LIMS would be capable of having quite robust LIMS rules, but unfortunately we do see this every year where units are inappropriately electronically issued. And then the smaller chunks were things that you're probably expecting to see. So not irradiated, people using an invalid sample, or not K negative when required. So this was just an image just to make sure that your LIMS are appropriately set up to adhere to MHRA requirements to do with electronic issue, because obviously some are definitely slipping through the net because we are seeing them every year. Okay, so when we look at the incorrect blood components transfused as a whole, so this is both lab and clinical, what kind of gaps and what kind of weaknesses did we see? So we saw gaps in staff training and knowledge. This was a resounding theme across the whole of the shop report, actually, just people struggling for staff, and then in turn struggling for that skill mix, making sure you've got the right skill mix, both in the lab and the clinical area. Communication failures, this tended to be in particular groups. So, for example, in shared care groups, and that might mainly affect people with hemoglobinopathies, transplant patients, and cancer patients, people who are being looked over maybe multiple departments within the trust, or multiple hospitals, or maybe multiple organizations. So those, making sure that the right information is passed between all areas. There's been a weakness in that point and has resulted in an incorrect blood component being issued. IT issues, we most certainly see a big chunk of errors, both clinical and laboratory, due to IT. So IT is obviously a way that we would encourage to try and reduce errors, but often with it comes its own problems. And sometimes it's just used suboptimally. Sometimes it's available but not used. Sometimes people don't know the downtime procedure when IT isn't available. So these are the kind of things we'd started to see. Suboptimal safety checks. So one of the big recommendations for SHOT has been to use a pre-administration checklist prior to administration of the unit to the patient, and we've started to see more and more gaps in that area. So the checks, either the checklist itself has gaps and isn't identifying particular errors, or it's being done and it's sort of being just used as a tick box. So people aren't necessarily identifying that there's something wrong and then mitigating that with actions. So we've started to see that. Increased pressure in emergency situations. I think that's probably quite obvious that in emergency situations, things are going to stress the staff and facilities and resources, and that obviously can sometimes impact on the patient as well. So we've got lots of resources available. These were like safety measures that we've got available on the shop website. We've got an example of a transfusion checklist. We've got an aid memoir for pre-transfusion administration. We've got lots of information about human factors and how they can impact on processes and people. And we've also got a fantastic document about implementing IT throughout the transfusion process on the website. It's well worth a look at. You can look at it from a particular 10 steps if you've got gaps in areas, or or on the other side, you can also view it if you're looking at particular processes, for example, electronic blood management, or temperature monitoring in the fridge. So it's a really fantastic document, well worth a look. And one of the things we've started to encourage hospitals, and we are seeing more take up of this, is a laboratory exit checklist. So having a checklist in place, whether that's just on a whiteboard that you can review and check manually and eyeball the unit and the documentation that goes with it, or whether that's a formal actual checklist. We wouldn't necessarily encourage one right from the other, but we are seeing more and more hospitals encouragingly introducing a checklist like that. So that's fantastic. One of the things we've also got available on the shop website is under educational resources. We've got a cumulative shot data by category. So if you if you open that page, it will open up to the page on the right-hand side, and Incorrect Blood Component Transfused has all of the resources to do with IBCT events all in one place. It's not the only thing there. There's also, for example, there's ADU and delayed transfusion reactions and allergic transfusion reactions. It's well worth a visit to that page because there's an awful lot of information on specific topics. If you were unsure as well, if you wanted other information or other help for out there in the clinical area, these are really great references. So these are both mobile and web application apps. So there's the blood components and the blood assist. So that QR code will take you to this page where you can find both of those. So rather than giving you two separate ones, but really, really helpful and really well worth visiting those and seeing if they could be incorporated into your areas. So to end on a slight better note, this is an ACE case. So one of the things that SHOT do is we produce a ACE chapter where things have gone well, often in the face of adversity. So this was a case where an organisation had reports of cases of specific requirements not met when managed between two different hospitals. They created a special requirements form which must be completed for every transfusion. The form is used not only when you're requesting the units at the beginning, but also at collection and at administration. They updated on EPR. I think they added specific requirements, not just a general one. They created a radiated and CMV as well, just to try and give people more information when they're viewing the EPR system or the electronic patient record, that they was highlighting that there was something to be concerned about. The laboratory produced a report monthly to do with anybody that's requiring irradiated, and all of those patient records were checked. And they also wrote to the patient's GP with an information leaflet and an irradiated card. So this hospital had really considered lots and lots of variables on how to reduce those specific requirements not met issues. So what kind of things would we recommend going forward? So I definitely recommend reviewing your patient ID processes. That is not just a transfusion thing. I think sometimes we hear back from reporters that patient identification doesn't necessarily sit in any particular training session. It might not sit with transfusion, but it absolutely needs to sit somewhere, and I'd try and review those. Can you improve your communication links? Are there ways that you can improve communication between departments, between hospitals? Can you maximize your IT? Have you got IT in place already? Can you improve on it? Can you look at the LIMS alerts? Can you get rid of the ones you don't need anymore, or the ones that are outdated, or the ones that are confusing? Can you simplify? Can you red, amber, green those alerts? Can you do anything that would help staff issue the right and the safe components? And I would absolutely encourage you to investigate any near misses before an error actually occurred. And what can you do? You could share any of your knowledge widely, share this presentation, share any of our resources widely. You can add them to the training packages if you've got. You can forward them on to your link nurses. You could take part as any of these events and use them as CPD. So it's just to spread that word as far and wide as you can. This is just a final parting shot that it isn't any one person. We are a huge linking process, aren't we, in transfusion, from the clinical areas to the lab areas and everybody in between, the porters and the switchboard. So it's just that to encourage that everybody is involved, and it's everyone's responsibility to make sure that we produce patients receive a safe transfusion. Completely self-promotion. We have got our symposium in like, what is that, 10 weeks away? The 11th of July, we're in Birmingham this year. We'd love you to attend. If you want to scan your QR code, that will take you to our website where you can have a little look about the agenda, what's going on, who's speaking, who else will be there. And so we can really promote our transfusion learning. And that's it. So I will stop sharing there. Hopefully everybody will join me on the panel for any questions.
Thank you, Nikki, for the presentation. So as Nikki just said, we are now going to move on to the Q&A for the next half an hour. Please add your questions to Q&A tool. This is the opportunity to get your queries answered. So we are going to move to the first question, that is, what role do IT systems play in preventing or contributing to ABOI transfusions?
Shall I answer that one?
Yes, please.
Megan may want to mention as well from IT. Yeah, absolutely. There's IT could have prevented some of the ABOs that we saw this year, but unfortunately it wasn't used or it was used incorrectly. So it's just really making sure that you have really robust IT, that staff are trained to use it. You've validated it and you've considered human factors when you're doing that. You've considered how people use it, and equally when it doesn't work, that you've got a process of downtime process as well. So we most certainly saw IT in those ABOIs this year. I don't know if Megan writes the IT chapter in the shop report.
Thanks, Nikki. Yes, I mean, certainly we know from the near misses, for example, that using electronic checklists and using electronic bedside IT does prevent wrong blood. So I think we know that IT can make things safer. The problem is that it's an adjunct to knowledge and training in this area. So either if your IT hasn't been fully implemented, fully trained out, or one of the things that I think we've noticed, Nikki, is sometimes when the alert messages don't necessarily mean things to people. So if at the bedside you get an alert saying, you know, don't transfuse this unit, and you don't understand why, that often is the situation where people would override that, particularly in an urgent situation. So I think both SHOT and also the IBI recommendations are to implement IT as widely as possible. We hope that over a longer term, as this is happening, it will reduce the number of errors in this area. And then at the same time, we'll see a new set of errors that are arising because of the IT. But I don't think that should put us off doing it. I think it does definitely improve patient safety.
Yeah, Megan's absolutely right. I did a 5-year review on the near misses to do with wrong component transfused, and a big chunk of those were detected using equipment. So that would be IT, whether that's a handheld system or a scanning system. Checklists were the biggest preventer, but absolutely IT played a huge part and prevented, from my memory, in 5 years study, something like 65 ABO incompatible red cell transfusions. So absolutely important, and they are making patients and transfusion safer. Absolutely.
Thank you both. We've got a question from James Davis. Thank you, James. It's well known that labs are suffering chronic understaffing, loss of experienced workforce, and difficulties recruiting. Is the increase in lab errors a product of this?
Yes. Absolutely. I couldn't agree more. We are, and unfortunately, having just written the most recent SHOT report that is due out in the next few weeks, that unfortunately is only getting worse. I think the pressure on those staff, the recruitment and retention issues, you can't get band 6s in onto your shifts, so you're expediting people onto shifts quickly. The people are having to reduce the number of training days they get to go on to shifts. That constant hamster wheel of staff just not getting the training they need, and I'm sure that is felt across the UK. I don't think that's any particular area or any particular hospital, but yeah, we absolutely are starting to see those impacting more and more. Yeah.
Thank you. Mike or Megan, anything to add there, or we can move on?
So I think the UK TLC standards that have been reissued now, I think are helpful. I don't know how many people are able to gap analysis test against those within their laboratories, but I think that's definitely something that gives you a bit of extra information and power, as well as the details from the SHOT report. And again, going back to the IBI recommendations, one of those recommendations was around staffing. And so I do know that that's something that's being looked at a sort of national level. It's not as easy as all that, though, is it, to solve it? But I think the fact that it has been recognised and the IBI is behind it has to help us. But at the end of the day, we need people to be able to recruit. We need to inspire people to want to go into our transfusion laboratories where they work under incredible pressure and do incredible work. But we need people to join us, really.
Yeah, I know the transfusion transformation team have also looked at, for example, the university courses as well, making sure that those courses have sufficient transfusion content. So the people leaving uni, like Megan was saying, you're receiving people into the role who have sufficient knowledge as well to then go on and receive additional training. So I think the whole process is being looked at. But yes, obviously there are. We can see it's a system under pressure. Sorry,
Thank you.
Okay.
Sorry, Mike. I don't know if you wanted to add anything, Mike.
No, the only thing with regards to capacity specifically, I haven't got much else to add, but almost every inspection I do now, there's a capacity issue in one way or the other. And one of the common themes is that if you have got a capacity plan in place, it hasn't been reviewed, so it hasn't kept pace with the increase in the workload that you're experiencing. And the other thing that I would mention is don't be afraid to mention in your incident investigations that you get to a point where you can actually identify a potential capacity issue, certainly when lone working, etc., and make sure that's made clear in your tracking and trending as you go forward, because then you can use the evidence to potentially ask for uplift in certain, if not staffing, but certainly technology. That's it. Thanks.
Thank you all. So now we have a question from Jane. It is a big one, but it's very important. It's about patient identification. So I'm going to read as it is. So it says, I was asked to contribute to a review of a patient identification policy recently, and there seemed to be a general perception that positive patient identification is covered in undergraduate preparation for all. Which it will be covered in the context of blood transfusion, education, medication. I'm not sure this is afforded in its own important place in undergraduate preparation. We teach medical students towards the end of their preparation and have received feedback that this is the first time that practical positive patient identification has been explored in detail. Do you know if there is work going on with universities to raise positive patient identification as priority? I think this is very important. Who wants to answer?
I don't know if it's covered in undergrad from a clinical perspective. I think you're absolutely right that it's often overlooked. I think when you get into the hospital as well, there's no particular place for it. So I don't know if anybody from the team knows on the clinical side.
I can only speak for nursing, and it is going to be part of the Future Nurse programme. I think there's a request that it's mandatory, but it is sort of gold standard, and it's also taught in preceptorship. For those of you who don't know, Future Nurse is an NMC, Nursing and Midwifery Council initiative. So, but I can only speak for nursing there. I'm not sure about medical. I don't know if you've got any knowledge on that, Megan, but certainly an interesting question.
Yeah, it's a very good question, Jane. I mean, I know that the transfusion medicine SAC of the Royal College of Pathologists is looking at undergraduate education. I'm not for doctors. I don't know where they are with their survey. There are GMC standards about training for medical students, but this is going down to a detail that probably is not covered by those standards. I mean, I think where people do have influence over undergraduate training, I think it is important to raise it. So I'm sure you are doing that locally, but raising it here is very helpful. And what I can say that we will do is to take that back to the RCP group that are looking at it and see whether we do know that information, and if we don't, whether we could find out.
And from the short perspective, the wrong blood infused, it is the highest category, and we get high numbers every year. And I had actually a conversation with a midwife that finished her graduate last year, and she mentioned that she was surprised how patient identification was just mentioned in the end of the degree as almost like an afterthought, when it's something that is so important. Everything starts with a sample, and if the sample is not from the right patient, it can have a cascade of immense cascade of effects for the patient. So thank you very much. Does anyone want anything to add? Sorry, Emma.
No, I was just going to say, I think as everybody's aware, it's not just a transfusion problem either. However, I think we're excellent at picking it up in transfusion. But, you know, certainly when I was working as a transfusion practitioner, I remember 1 or 2 cases where it was picked up during transfusion, but actually these patients had undergone x-rays, you know, they'd undergone lots of things, they'd had controlled drugs without any identification being checked or a wristband being, you know, not present. So yeah, it's definitely true. It needs a definite joined up approach and thinking, I think. Thank you. So we've got another.
I was just going to say, there's a nice short video, I think, on this as well, isn't there? That we
there is,
could,
yeah, well
promote.
Remembered. Yeah, there is. We can try and put that link in the chat. So the next question, just moving on, is how can we make the LIMS flags more effective to prevent staff not heeding them when they are present? Maybe one for you, Nikki.
Yep, we absolutely, the flags are really important, but I think what we would always promote is making sure that they're appropriate, they're clear, and that there's an action associated with it. So I know when we were building an LIMS system myself before, you're so overwhelmed by, oh, I can put a flag for that, I can put a flag for that, oh, that's brilliant. But actually what it does, it creates alert fatigue. There's just so many alerts, and they pop up at so many different points, to the point where you're allocating the units, and then when you're issuing the units, you just become blind, unfortunately. So I think our advice for, particularly for alerts, would be clear out the ones that are no longer needed, review them. Can you simplify them? Can you make sure they're actionable? Is there some way of RAG rating it, like red, amber, green? Can you make it really clear? I mean, it doesn't mean that they won't be overwritten, and because there are absolute times in emergencies where they need to be, but I think Megan will probably agree from the IT chapter that alerts do unfortunately play a part in an awful lot, not just incorrect blood components, across the whole shop report, that alerts are there available, and they're just not understood, so they're overridden, and they go on to transfuse the unit anyway.
Can I just sort of come in there and say that don't forget, again, with your incident management, don't focus on the alerts, focus on why they were ignored. And if you're rushing, I mean, many that I see, people, you know, the reflective statements say things like busy, rushing, and that sort of stuff, which may be more prone to, again, a capacity issue, as opposed to, because these alerts become familiar, so you just click through them, as Nikki's just said. So, you know, just understand that the causes aren't just because of the alerts. They're sometimes because of the way people are using them, not to blame the individual themselves, but the processes and systems that they're working within.
Yeah, the other thing I think is that sometimes the alerts may be understood by the laboratory and not by the clinical area, because they might have different nomenclature in them that is more familiar in the lab than is in the clinical area. So one of the things we did when we did the Meet the Experts IT webinar is we looked very specifically at things that went on in the clinical area, and there was a lot of alerts that weren't understood. but obviously, you know, you need your limb system to be able to prevent the issue of ABO incompatible blood. I think that's a fairly fundamental thing. That would be in your BSH guidelines. It would be in your specification for your IT system. But each IT system does that differently. So if you're moving from one lab to another, or you're moving from one clinical area to another, you need to be specifically trained on the system that you're using, because they're not standardized. The script group is thinking of trying to develop some standards for standard alerts that we can work with the manufacturers on, but I think that's quite a long way off. We recognize the need for it, but how to actually achieve that is a bit more difficult.
Thank you all. So let's moving on to the next question. So how often are patient comments on the processes taken up?
Say that one again to me, Vera. I'm sorry. How often are patients?
Are patient comments on the processes taken up?
Well, we obviously encourage a patient representative when you are implementing processes as well. Do you mean when patients are feeding back on when they're asking for their ID? Is that what you mean? Is that what the question means, do you think?
Maybe when patients comments on how things are done by the health in the hospitals, if it is considered, if it is actually acted on?
I would hope it would be. It is been one of our main recommendations to listen to patients for several years from SHOT's perspective. Having that feedback loop is so important to make sure that, because the patient may spot errors that you've never even considered, or issues and gaps that we'd not thought of. So I'd hope that they would be considered. I think probably following on from what Mike was saying about how stretched and how busy areas are, how much that is taken on board. I don't know. I don't know if Emma from the clinical side.
Yeah, I agree. I mean, we have patient feedback surveys and things, and there is consistently that message, I think, to patients, particularly in transfusion. You know, I can't speak for other things, but one of the things we are kind of releasing quite imminently in the next few months as well is a patient-facing app for transfusion. And again, one of the consistent messages we've got throughout that for patients is to ask really to speak out. So if they notice they haven't got an identification wristband on, you know, if they notice something is untoward with the unit of blood they're about to receive. So I think it's just constantly reiterating that message, and hopefully giving patients that sort of confidence to speak up if they notice something that's not quite right. I think Shruthi's joined us now. I don't know if you heard that, Shruthi. We're just talking about a patient's sort of concerns listened to. I think that was the basic question. Sorry, put you on the spot there when you've just joined.
Sorry, Emma, my audio was not working. Can you repeat that?
That's okay. So the question was, how often are patient comments on the processes taken up?
Oh, you mean within our processes?
We think so, yeah.
Okay. No, thank you. Thanks, everybody. And apologies. So I think we have a couple of patient representatives who are sitting on the SHOT steering group, but also we engage with patient representatives on specific projects. Like, for example, team may have mentioned it that we have been working on a My Transfusion app, which is going to be released soon. For that, we have actually then had patients who have been regularly transfused as well. So I think it is, other than regular operational matters relating to our hemovigilance activities, but also on specific projects, we do endeavor to actually then get input. And we are also exploring ways of actually engaging with them even more. So I think watch this space. And they may have already mentioned about the patient information page on our website as well. So watch for more developments as well. Thank you.
Thank you very much. So another question we've got from Mercy is, how best can we report patient blood group post BMT, bone marrow transplant, when group has not fully converted? Is reporting cardinal group recommended where blood group is not fully converted?
I think that is outside of the scope of a hemovigilance that I would say, but there's also ways of, we do have a document about interpreting mixed field reactions as well. But in the transplant setting, I think it makes it all the more challenging because the chimerism as well would be actually varying depending on the phase of the transplant. I don't know if any of my other colleagues also want to actually come in.
Yeah, I think it depends on your limbs capabilities as well, doesn't it? Some are really fantastic that you're able to put in as the patient progresses through their transplant and things change. But I have never worked with one like that. So I think it all depends on what your limbs is capable of doing.
Thank you both. So the next question is about specific requirements not met. So when issuing blood for a pregnant patient in labor ward to cover delivery, as it is delivery, and if it's not available, is safe or acceptable to issue no CMV negative, or this should be always met?
So I can see the question. Yeah. So obviously we would just recommend you went with the BSH guidelines. So anyway, you can't meet that. That may be the case in certain hospitals, depending on your stock level and things like that. Then you would have that concessionary release documentation. I know that guideline is being updated, and that is one of the things that SHOT are looking at. We are very conscious that more of our reports that patients are really complex, and people aren't sure when they can't meet the requirements, which ones they can and can drop. So that is something that Vera has is in the process of creating a very wonderful table to really try and help people, because particularly these are difficult situations, aren't they? They might be emergency situations as well, which made it all the more difficult. So my recommendation would be to go with the guidelines, which and then if you can't meet those requirements, concessionary release. Shruti, sorry, you've got your hand up.
No, thank you. Thank you, Nikki. And I think for any of these special requirements, whether it is in the pregnancy setting or a non-pregnancy setting, the main thing that would be guiding feature is actually the urgency of the transfusion. And therefore, as you already are aware that the transfusion delays are one of the most common causes of deaths that are reported to SHOT as well. So therefore, for emergency transfusions, please don't worry about the specific requirements, whatever be the situation, whether it is pregnancy or not. And however, for elective transfusions where there is actually a bit more planning that can be actually done, then yes, that would be actually the opportunity for us to actually ensure that all the specific requirements are met. So I think the main thing would be that in these situations, it is actually difficult to give a generalized answer. It is actually about the urgency of the situation, discussion with the clinical team, as well as the hematology or the transfusion team, so that you know how much is actually the delay in anticipated there, and then make the decision. It is weighing the risks and benefits and then making that informed decision.
Thank you. And the next question from Julie. Thank you. So it's more of a statement really, but I think we can turn it into a question. So there's still misconception that the lab will already know the specific requirements for a patient. The healthcare team do not appear to have knowledge. We produced a poster aimed at trying to inform, but there are so many posters which all look similar that staff become poster blind. I can certainly relate to that, Julie. And I think, the dangerous posters can very quickly come out of date as well. So I guess the question within that is, how can we help the healthcare team have knowledge, or this misconception that the lab will pick up, already have that on their records?
And I think, sorry, I didn't raise my hand, but I think just to butt in that, I think assumptions always will lead to a lot of, errors and avoidable, preventable errors in healthcare. So I think the important thing is actually don't make any assumption. And the laboratory team are excellent, but they'll only know if the clinical team have actually provided that information for them, whether it is actually from, the type of the chemotherapy, or the underlying clinical condition that they are actually having. So I think please don't assume. And equally, the patient may have actually then come to the hospital for the first time after having a treatment in another hospital. So especially for patients in shared care. So it never will be harming. And that's why I think when all the request forms, one of the fields or the mandatory fields should be actually that, specific requirements. Equally, when the blood is actually issued from the laboratory as well at the clinical end, again, that ultimate step where before the blood is put up, that check should also be actually then is the specific requirements are all met as well. So I think it is that equal information sharing. And, it is always useful when the lab gets it from multiple sources, it's fine, but it's actually each one assuming that the information is available then may lead to complete miss of that information as well.
Thank you. We have a question about one of your slides, Nikki. So you have said that on the 10 steps of transfusion slide that one of the errors is due to issuing group specific on one sample. The question is, they cannot see on any report as explicit cause and represented by numbers. How many incidents of ABO incompatible are from trust releasing blood on only one sample? And how many hospitals in the UK are on one sample policy?
So, so this is where, yep, so it's where the error has occurred. So they've issued a one, so they're not choosing, that's not a choice by them to issue on one. It's just, it was an error. So the right process should have been to issue on two, which is where we've seen the issues. And we do have different sample errors. And depending on what it is and where it occurs in the process, it will always live under the incorrect blood component transfused umbrella, and it might live in wrong component transfused if they've got no history, or it might live under specific requirements not met if you've just not completed some testing. So we would decide that. So I wouldn't worry from your end if you are reporting an error and you're not sure, report it as a general report. The numbers, the question was numbers. I can't remember I don't know if we had any last year, but over the last 10 years, we did look at testing in the lab as issues, but I can't off the top of my head remember. But it tends to be where it's something, there's nothing in the limbs to stop you issuing based on one. So you might be issuing group specific based on one sample without having a confirmatory group. So we would class that as reportable, definitely. I don't know if that answers the question. I hope.
No, I think the latter part of the question was actually, do we know, how many hospitals are in the UK are on one sample? And I think the answer is yes, we don't know that information. There had been one ABO incompatible, if I remember, in the recent years. That was 2 years ago, based on a historical VIBIT. Wrong blood in tube incident for a historical sample, and then there was an ABI, but no. And I think the message that we really want to actually convey from this is that there are safety critical steps in the pathway. So it is that collection of the blood component, administration of the blood component, issuing set, all these different steps where errors could have been actually then introduced as well. And again, avoiding those cognitive biases as well as the assumptions would actually then really help.
Thank you. Sorry, Vera.
I was about, so thank you, everyone. We have now run out of time for questions. It's almost 2 p.m. If you have any burning questions or we have not answered your questions, please email them to us and we'll forward them to the experts. Thank you all for the interesting and useful discussions and for the questions that have been added to the Q&A. Next, we are going to launch a short poll for all the attendees. It should only take a few minutes, and your feedback is really welcome as it helps us to shape these webinars, as you can see. So while the poll questions comes up in your screen, I just want to inform that today's webinar has been recorded, as you may have noticed, and it will be available on the SHOT website in a couple of weeks. You also found on the SHOT website the registration for the next webinar. The next webinar will be on the 9th of June, and as we've been actually talking in this webinar, is going to be focused on patient identification, is going to be focused on near-miss reporting and wrong blood in tube events. We also have now a LinkedIn page where we promote regularly these webinars. There's also some resources, so please just check our page. And for this session, will not be available any certificate, but you can use your reflective practice document or equivalent from your local organization, and you can record this webinar as a CPD activity. Again, if you have any questions that you were not answered today, please email us to us. Our email address is shot@nhsbt.nhs.uk. We are just going to leave this poll for a little bit longer, for another minute. So I'm going to close the poll now. I would like to thank you all for joining us today. It has been a fantastic discussion, and I hope you have found this session very useful. We'll now close the webinar, and I hope to see you at the next one on the 9th of June. Thank you very much.